Good evening, how are you? Wish you are fine. I want to speak about the Asian rhinoplasty. Of course, we should make local anesthesia in the nose and during or making or extracting the cartilage. Local anesthesia typically is 1% lidocaine with epinephrine in 1 to 100,000 concentration, which is injected onto the nose and chest using a 27 gauge needle. Even under general anesthesia, the local anesthesia with adrenaline improves postoperative analgesia, reduces intraoperative bleeding, and allows for a tighter plane of anesthesia. Key injections for the nose include internal and external sites. The symptom is injected in a submucopericardial plane to assist with hydrodissection of the soft tissue from the septal cartilage. The vestibules are injected along the marginal incisions. The piriform aperture is infiltrated along the nasal side walls externally and lateral nasal cavity internally via a needle stick just above the inferior turbinate, anterior attachment to the maxilla. The dorsal skin is infiltrated in the supratip perichondrial plane over the upper lateral cartilages and supraperiosteal plane above the nasal bones to achieve hemostasis of the vascular area. The tip and columella are injected from a median needle stick between both domes. Following identification of the cartilaginous portion of the rib, local anesthesia is infiltrated along the pericardium and within the dermis at the site of the planned chest incision. Local anesthesia injection precedes iodine sterile scraping in order to allow ample time for the medication to take effect. Now, according to the cartilage harvest, costal cartilage harvest typically proceeds the nasal surgery in order to maintain sterility and decrease the possibility of cross-contamination from the nose to the chest. Several choices exist when harvesting costal cartilages. Cadaveric studies have advocated harvesting the seventh ribs as an ideal choice because of its superior length, greater thickness, and its location inferior to the lung pleura and lateral to the course of the internal mammary artery. The senior author prefers the sixth rib due to its close proximity to the inframammary crease. Sometimes both sixth and seventh ribs are harvested through a single common incision when a large amount of grafting material is required. Grafts for dorsal and premaxillary augmentation. The fifth ribs has the benefit of fewer connection to neighboring ribs, but it tends to be more curved and short than the sixth rib. Selection of the rib is thus case specific and depends upon accessibility, presence of calcification, volume of graft required, and rib configuration. Preoperatively, a thorough history should include questions about previous chest surgery, breast augmentation, and types of breast implants if present. In the female patient, breast size can limit the surgeon's ability to adequately expose the more superiorly situated ribs. Access is further complicated by the presence of implants that both increase the breast size and require a more inferior dissection path in order to avoid entering the implant capsule. The harvesting procedure begins with the skin incision and sharp dissection through subcutaneous adipose and breast tissue down to the pectoralis muscle fascia. The fascia is sharply divided and the muscle fibers are bluntly spread using a hemostat. Blunt dissection with a cotton dissector clears the remaining soft tissue of the rib to expose the pericardial surface. The osseous junction is confirmed using a 27 gauge needle, and this landmark marks the lateral most extent of the useful costal cartilage. The pericardium is incised along the osteochondral junction and along the superior and inferior edge of the anterior surface of the rib to create a window through the pericardium to the cartilage below. The strip of pericardium within the window is elevated with a freer elevator excised in a 5 to 8 centimeters length and stored in sterile saline for later use. Next, the rib is dissected away from the remaining pericardium circumferently, taking care to avoid injury to the deep pericardium, which intimately overlies the lung pleura. An incision is made halfway through the rib, just medial to the osteochondral junction. A medial incision is also made based on the length of cartilages required for the augmentation. A blunt-tipped freer elevator is used to complete the cartilage incision and dissect through the neighboring rib costal attachment. This isolates the dissected segment of costal cartilage, which is removed and set aside in sterile saline to soak. Attention is then directed to the medial and lateral margins of the in situ rib. A rongeur is used to bevel the sharp edges, which prevent potential visibility or edge palpability. Irrigation solution is then installed into the surgical bed, and the anesthesiologist is asked to perform a Valsalva maneuver. If there were any openings into the pleural space, bubbles in the irrigation fluid would indicate an air leak. Closure of the wound is deferred until the end of the procedure in case additional rib or pericardium is needed. The wound lightly packed with a moistened cotton gauze and covered to maintain sterility. The most technically challenging aspect of augmentation rhinoplasty using costal cartilage is carving the graft. Costal cartilage must be carved sequentially over several hours with frequent soaking periods to allow the natural wrapping tendency of each piece to be declared. The dorsal graft must have minimal wrapping and is best carved from the central core of the rib. That's all about extracting a graft from the cartilage. I wish that you see the whole video. If you like the video, please subscribe to my YouTube channel, like, share, subscribe. Again, thank you.